I'd like to welcome everyone to the HSPN monthly webinar focused on Ontario health teams. This month, we have another version of stories from the field, and we have great, wonderful guests and speakers from Chatham Kent, KW4, and North Toronto to talk about population segmentation. Please, if you're joining us for the first time, well, it doesn't matter if you're joining us for the first time, please open the chat box and let us know who you are. Make sure that you click to everyone, and then we can all see it. So please let us know who you are and where you're from. Jenny from North Toronto, welcome. And Kim McKinnon from Good Shepherd. And here is now, it's going to speed up. Dulap Bibi, Karen Gallagher. People are just flying in now. Great to see everybody. Monroe Ross, Chris from Kuchiching, welcome Chris. Anita Tressler from Sarnia Lambton, Charles from Ottawa, Jenny from St. Catharines, Nancy from Alliston, Family Health Team, Leslie McGough, welcome. Hi, Mike from Rise as well. Rebecca Paul from Muskoka. I was just up in Muskoka yesterday for the weekend. I enjoyed a little bit of winter up there. It's winter here too, but it was nice. We have a little spot on a remote lake, and we were able to get out, skate on the lake and stuff. So it was quite beautiful up there. Cheryl from Huron Perth Elgin, I believe, HPE, if I get my acronyms correct. Welcome everybody. Please continue to type into the chat. Let us know who you are and where you're joining us from. We have an amazing lineup for you today. I see we have almost 200 people online so far, so people are coming in quickly for this great webinar. I think it's quite a popular topic. First, I would like to acknowledge the land. I am speaking to you from the University of Toronto, and this land for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work on this land. You are joining us from many other lands across the province and nationally in some cases, perhaps even internationally on occasion. And I welcome you to acknowledge the land that you're joining us from as well. We're going to start just as everybody continues to chat in to let us know where you're from. Brian Dunn from London Elgin, looks like a few OHTs. Liddy Zhu from Sarnia, Hamilton, welcome. Yeah, I'm going to open up the first poll just to see how many people are joining us for the first time. So if you could let us know if you're joining us for the first time. Click yes or no. And I see that the poll is launched. I can't see the respondents coming in, so I'm going to just gauge this from my recollections of how long it takes people to click in. I think people are quite quick about it. So I'm going to close it off in about 5. And then we can let everybody know. Not seeing the poll. Oh, there we go. That was a 2-click poll. So thank you, Nusrat. I'm going to need your help on this because I couldn't, it looked to me like it had gone up. Thanks to the folks for letting us know. And I can see everybody was eager on their fingers. We're at 130 people in already, coming pretty close to most people in for whether you have joined us before versus being a first event. We're going to have to do some trending on this number, coming close to saturation now, because I think it's remarkably close. I don't know, Nusrat, if you need to do something else to push that button and send it out. Hopefully everybody can see that it's 78% have joined us before, but 22% are here for the very first time. And that's in the 20s seems to be a pretty close number where we continue to bring in new people to these events, but we also have quite a few returning. I see that we're actually up to 215 respondents now, so not everybody got in for that poll at the time. There will be more chances to join in other polls interactively along the way. It's my great pleasure today to spend just a moment introducing some of our speakers, well, all of our speakers that are coming from different OHTs. We have 3 OHTs represented today. Some of you may recognize Lauren Tessier, who was here to talk to us about population health some time ago, as part of one of our introductory webinars on population health management. Lauren's an OHT Impact Fellow working with Chatham Kent Ontario Health team. Very, very pleased today for the first time to have KW4 represented. Caitlin Agla is going to join us. She is the director from Hospice Waterloo, and she has a master's degree in social work with a specialization in gerontology and is a registered social worker. She's currently working as the Director of Community Client Services at Hospice Waterloo and is the co-lead for the Frail Elderly Working Group. And we're going to hear about that Frail Elderly Working Group and their progress in KW4. Holly is newly joined the North Toronto Ontario Health team as a population health analyst. And she's working with the Quality and Operations Committee, working closely with Darren Gerson, who is the co-chair for the Quality Committee, and he's Vice President, Quality, Risk, and Performance. And Darren and I have had many conversations about population segmentation over the years. Darren and I have he worked at Kai many years ago, and I knew him from there. Okay, so we are going to, just a quick little part of the agenda. I'm going to give a little bit of an update for about 10 minutes because we get lots of questions in about what HSPN is up to. And then we're going to go to stories from the field. And I'm conscious of the time, so I'm going to go pretty quickly through this evaluation update so we can get into the reason everybody has joined us, which is really to hear about what's happening in Ontario Health teams. First up, in last month, I presented on some of the CQIP indicators. And I talked about Ontario Health teams being given access to the data that I was showing at the OHT level. And indeed, that's about to happen. OHT segmentation and indicator data, including CQIPs, is on their way. Each Ontario Health team evaluation contact will receive an email from one of the following leads. We're using a few different groups to share this data out: RISE Population Health Coaches, Ontario Health Team Impact Fellows, or the HSPN evaluation co-leads. You'll receive that email. I'll have the timing in just a minute. The email will invite you to set a time for us to discuss your results individually. As soon as we pick a date to review and discuss the results, we will send you a data package, and there will be 4 files in that data package for your team to review, and you can organize your questions and prepare for a discussion in advance. What's in the package? Well, first off, there's a PowerPoint presentation with results for the population segmentation and CQIP indicators. So we have population segments using the BC Health System Matrix. Last month, I presented on what the BC Health System Matrix looks like, and we have other information to support that work. You'll receive CQIP indicators graphically by the BC Health System Matrix segments. You'll also receive the CQIP indicators by material deprivation in quintile. We're interested very much in equity across these measures, as we are with all of our indicators. And then CQIP indicators also by primary care patient enrollment models. And I think you'll find that last month we highlighted that there were some market patterns, particularly around some of the cancer indicators, according to the primary care enrollment models. And so we're sending those to you as well. And then finally, we will also send you population segments and CQIP indicators using the CIHI population grouper. You're going to see more on the CIHI pop grouper today. We gave a little bit of an intro last September. There are 3 Excel files. The first one has all of our improvement indicators, yes, 25 indicators, including plus the CQIP indicators. And then we also have physician counts. We're sending these to you stratified by the BC Health System Matrix and by material deprivation quintile within one file. And then we have data for both 2019 and 20 and 2020-21. So the previous 2 years of data. You'll receive a second file that has all of that, but using the CIHI pop grouper. And then finally, there's a separate file provided to show all the indicators by primary care patient enrollment model. So 4 files, 1 presentation and 3 Excel files. And there's lots for you to dig into. I think you'll probably start just with the PowerPoint deck, but all the raw data sit there as well, which we'll unpack. Well, why is it taking so long? Okay, so there's 51 OHTs. There are 2 population pyramids with cost of mortality, 20 additional graphics for each team, 1122 images to create and insert. And the data tables, we have 10,098 data tables that we are clearing for re-identification risk to send to you. We will be contacting you between February 28th and March 4th with this, with our materials, and to set up a time for us to discuss. We are about to launch follow-up to our Ontario Organizing for Ontario Health Team survey. Many of you would remember that when you first were identified as a candidate Ontario Health Team, you received a survey from us, Wave 1 in January 2020, Wave 2 in January 2021. Now we have Wave 3, and we're going to be distributing to Wave 3, the first one, and then also Wave 1 and Wave 2 OHTs. We're going to come back with an update to see how things have changed. We also have a few new items related to governance and decision-making in the teams. You see on the left here, all of the domains that we captured previously. And we have all of those are going to be captured to see how the teams have changed over time since. So I think it's good for an update now. The survey links are going to be distributed on March 1st, and they will be distributed to, our list includes 1 representative from each OHT signatory organization. That's our sampling pool for the survey, consistent with the first time that we sent it around. We also have surveys available. This is more of on demand, on request, and some teams have asked us about this. We have patient survey that we can make available. There are 8 domains to this. We talked about this in our May 2020 webinar. We also had some representatives from our patient panel join us for that webinar, as well as a provider survey, which covers 5 domains around care coordination, workplace culture, autonomy, burnout or satisfaction, and digital or virtual care. And we have a few OHTs that have fielded these tools as well. If you are interested in those surveys, you can receive a package from our team, which will have a general link to the experience survey, some introductory wording for an invitation, our information letter according to our Research Ethics Board approval, and a PDF of the steps to follow. You can check out our website. We have some videos online about how this all works. And if you're interested, please contact oht.evaluation@utoronto.ca for this or any other inquiries. That is the end of my brief little intro. And I'm just a small point of clarification that we are using the updated OHT packages, attributed populations that were produced in the summer of 2021, so just last summer, which were based on 2019-20 data. That is the most recent Ontario Health Team attribution model data. Okay, now it's off to the fun track. Stories from the field. I first want to welcome Lauren Tessier from Chatham Kent Ontario Health Team. And Lauren has got a really great tale to tell of stories from the trenches. So Lauren, I welcome you to join us here, and you just let me know how to proceed.
Thanks, Walter. Good afternoon, everyone. So you can just advance to the next slide. Thank you for the introduction. So just to give everyone an idea of where this is going, I'll provide some high-level background and contextual information before getting into our segmentation approach and key learnings from the process. And then we'll finish up with an overview of our next steps and Q&A. Next slide, please. So as Walter alluded to, I think me being here presenting to you today about my real life segmentation experience can really only be described as kismet, because a year ago, last February 2021, I presented here as a trainee with the Health System Performance Network on some early work I had been involved in on population health management and population segmentation. And now here I am, humbled by on-the-ground experience that I didn't have a year ago. And I'm not saying that because segmentation is hard or is impossible, but coming from an academic background, how it turned out was not how I expected it to go. So really, in other words, it was not entirely aligned with the process set out by the literature. Despite this, we are now in a good place where we are readying ourselves to move into the next phase of population health management. And it really would not have been possible if we hadn't segmented the priority population. Next slide. So next slide too, sorry, Walter. So just to provide a bit of context for those of you who don't know, Chatham Kent is composed of many small towns and villages in the heart of southwestern Ontario. The attributable population is about 105,000 people, and the priority population was defined as individuals 55 and older who have one or more of COPD, CHF, angina, diabetes, dementia, and or otherwise complex. So provincially, this is 4+ chronic conditions. Depending on the data source, our priority population is somewhere between 10 and 14,000 individuals, so about 10% of our attributable population. Next slide. And a final point I want to make about our segmentation context that was really important to our approach is that CK has a high rate of material deprivation. So this figure is from the HSPN reports that were sent around last year. And from these, we learned that of all OHTs, Chatham Kent has the second highest proportion of its attributable population living in the most deprived quintiles. And as I alluded to, this fact was really critical to some of the segmentation decisions that we made. So you can skip to the next slide, Walter. Moving on to our approach and key learnings. So the first key learning is that our segmentation had to be iterative and flexible. I started my fellowship in September, and after having been using ICS data for the past few years, I really thought this would be a rapid process. I figured segmentation would be done in a month tops and would be based on linked data with multiple inputs from all individuals in our priority population. And obviously, I'm sure as you are all already know, I was quickly dissuaded of this notion. The reality was that the segmentation process ended up being lengthy, and I really think there's something to learn from this. So the first go at segmentation actually happened in the summer of 2021. This analysis was shared with me when I first started, and it essentially amounted to a 100-slide PowerPoint deck with a lot of data and a lot of figures, a lot of tables. And you might be thinking to yourself that we were fortunate to have so much data, and we were, but I think there is a downside to it. So segmentation is not data analysis for the sake of data analysis. And after all that data had been presented without a clear purpose, it left room for a lot of questioning that ultimately devolved into circular discussions. And by September, the committees that had been presented with that data really hadn't gotten any further along in the population health management process, and they were having a lot of trouble making decisions. So our process was iterative in that when I started, the approach to analysis and interpretation was adapted. And I know that not every OHT has a fellow that can act as a data intermediary, and we also had the benefit of working closely with our RISE coach. But I think the key thing to remember from our experience is that when you start analyzing data, you always need to keep in mind what it should result in. The whole purpose of population segmentation is to inform decision-making and co-design. So you really always have to remember the why for your analysis. What are the questions you want to answer, and what are the key things you want to learn to drive your co-design? And once you've determined that, you can move on, which is something I, again, coming from an academic background, really kind of struggled with at first. But it feeds into my last point, which was that real world segmentation needs to be flexible and responsive to on-the-ground constraints. When I was first able to get the segmentation data, I figured that I would analyze it, come up with more questions, ask for it to be cut in different ways, so on and so forth. But for a number of reasons, this didn't end up being possible. And in the meantime, the deadline that had been set to make recommendations to various committees was approaching. And so we had to take a step back to objectively look at things and decide that we actually had enough to make recommendations and inform decision-making. Next slide. So what you'll see here is that what we ended up doing is breaking down ACSC hospitalizations by diagnosis group, by age, and by material deprivation. In terms of key messaging, even though we had more data than this, when we presented this to various working groups, this was really what we focused on because we didn't want to overwhelm people and we wanted to be able to move things forward. So what we saw was that COPD in younger seniors was driving ACSC hospitalizations, and ACSC hospitalizations for COPD were significantly more prevalent in people living in the most deprived quintiles. And for anyone wondering, I will also quickly note that we decided to focus on ACSC hospitalizations rather than BME visits for 2 reasons. First, given our priority population, ACSC hospitalizations are a better indication of what individuals in our priority population are doing and how they're behaving, as the diagnosis, as our conditions of interest can actually be ascertained through the ACSC diagnosis coding. Second, and this decision was more strategic in nature, we were really trying to move the discussion away from kind of an intense focus that had emerged on ED avoidance. So obviously ED avoidance is a part of any population health management approach and integrated care pathways, but it really isn't the end all be all. Next slide. So the second key learning from our process is don't let perfect be the enemy of good. At this stage, no OHT has perfect data. So really all you can do is make evidence and context informed decisions and remember to keep the pitfalls of your data in mind as you move forward. The messaging that we adopted that was really helpful is that we were not seeking perfection through segmentation, we were seeking learning. Next slide, Walter. So as I had mentioned from the start, we knew CK had a high proportion of residents living in the most deprived areas. This important contextual factor drove our choice to use IDS data to do our segmentation because it contained information on patients' material deprivation quintile of the neighborhoods in which they lived. Not every individual in our priority population is captured in the IDS data. And in a perfect world, we would have individual level material deprivation data, but we don't. And we couldn't let not having that data keep us from using a legitimate proxy. And even though other data sources could have been used and maybe more people from the priority population would have been represented, those did not contain information on material deprivation, but we knew this was necessary to investigate our context. So before segmenting, we initially thought the rural population was driving material deprivation, but we learned that it wasn't. It's a mix of rural and urban, but a bit more strongly urban. And so now in our co-design, we know there are urban populations we will need to pay special attention to. Next slide. And so the final key learning from our segmentation experience is don't jump to solutions. We really grounded ourselves in an evidence-based approach to population health management, and that really helped us get us to where we are. And based on my own experience and observations, it's never too late to start. I really empathize here because I think OHTs are in a tough position. Distributed decision-making and planning are necessary, and I think COVID has created this weird dichotomy where everyone is exhausted, but at the same time, they want to move on and they want to get work done and they want to have something to show for these new partnerships that have emerged and these new processes that have been put in place. But this can sometimes create conditions in which things start to get away from you. One working group wants to focus on one thing, another wants to focus on another, and so on and so on. And with so much information being thrown at you all the time, it can be overwhelming. And I think the result is that sometimes people default to decision-making based on anecdote. We know this is a problem, so let's start planning how to solve it. And I will admit that as an OHT, we started to find ourselves in that position. And unfortunately, the tough reality is that in the long run, that type of process doesn't align with good population health management.
I'm sorry.
And what really helped us recenter everyone on the same purpose was getting everyone on the same page about the process we were going to work through. And we did this by presenting on the RISE population health management process to all of the relevant working groups. And like I said, it really helped refocus us and streamline our workflow. And so it's kind of here that the title of my presentation feeds in, building the plane before flying it. I know I've had a lot of different conversations with people from different OHTs, and the running joke is you kind of feel like you're building the plane as you're flying it. But by grounding ourselves in this process, I kind of feel that as a team, as an OHT, at least with respect to the work we've done so far, we feel like we have a good grip on things, a good understanding of where we're going next. Next slide, Walter. And so as I alluded to earlier, after segmenting our priority population, we came to this decision to focus our co-design on population health management on younger seniors with COPD. And I will admit that we questioned ourselves after this. We wondered if we should have just focused on COPD from the start. But I think if we had, we would probably still be stuck without a clear idea of how to move forward. And had we jumped to co-design, we could have built a program targeted at the wrong population. It was also important that we honor the population health management process, because as OHTs scale and become responsible for more and more populations, and eventually their entire attributable population, this is a process they will need to become skilled at. We figured it was better to familiarize ourselves and our partners to this process early so we could start flexing our population health management muscle. Next slide. And next slide. So our next step, again, is co-designing integrated care pathways for individuals 55 and older with mild to moderate COPD. So really what we're focusing on is connecting to a successful program that already exists in the Southwest region for patients with COPD and building that up. We're trying to think about how do we spread, how do we improve, how do we integrate, and really having the right voices at the table. And something I'll mention too that, again, I think has helped us really get a good grip on things is, like many OHTs, we added on additional priority populations after defining an initial priority population. So for us, that was individuals experiencing mental health and addictions challenges and people in need of palliative care. And again, to really kind of delineate what we're doing, what we're trying to figure out through co-design is how we can integrate mental health and addictions and palliative approaches to care into our COPD pathways. And I think that's going to create a lot of opportunity for good integrated care to be designed and to eventually happen. And then those kind of cross-sectoral conversations that will happen at the co-design table, they're going to have a really strong foundation again as we scale to other populations. And that's it. Thank you so much. I have my email on the next slide if anyone does want to contact me for questions or whatever, and happy to answer questions now too.
Yeah, thanks. And there are one or two who come in, and I'll ask those in just a second. Thanks so much, Lauren. And I just want to comment before we go to this poll on appreciating that the point you made about as you move into your future populations, thinking about how some of those also apply to this population. So particularly palliative, also applying to COPD, because a good number of people in with advanced COPD are heading towards models where palliative might be an appropriate approach. Okay, I am going to pop up a quick little poll here, just asking where people are at in terms of segmentation efforts to date. Have you not started, just beginning, or did you, as with Lauren has highlighted there, started in with the first year population? So thanks very much. We'll see everybody coming in, still a number. There was a quick little factual question, Lauren, on whether you had used Intellihealth. I think you mentioned that you used IDS.
Yeah, so we did not use Intellihealth. We used IDS, which is a system that I'm fairly certain all of the hospitals upload onto. And then depending on the OHT, sometimes their home and community care sector also uploads data onto IDS. So depending on which OHT you're in, you may actually have access to linked data if your home and community care sector and your hospital both upload to IDS. For us at the Chatham Kent OHT, only our hospital uploads to IDS. And so we didn't use Intellihealth. Again, we used IDS because we were really driven by that material deprivation decision. Given how high our rate of material deprivation is in Chatham Kent, we knew that we had to factor that into our segmentation in some way. And, I think what happened on the ground was I had to get familiar with the different kind of data sets available. And by the time you're able to meet with people, wrap your head around things, blah, 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 a month has gone by. So now it's the beginning of October, and we had set a deadline of December. We wanted to be able to present to, the various working groups so a decision could be made about how to move forward. And so again, it's really on the ground constraints that I think sometimes drive decision making. And I don't think that's a bad thing. I think sometimes in research, you always want a little bit more time, and then people on the ground are like, you need to make a decision now. And so that was okay. Like sometimes you kind of need to know when to introduce a stopping point and when you have enough information to move forward.
Yeah, thanks for sharing that. I see, I don't know if you can see it or not, but in terms of segmentation, about a third of people hadn't yet started. 55% they said they're just beginning, so that's great to see. And I think this is a very timely webinar then for those folks. And some people had about 13% having completed for an initial priority population. So it gives you a bit of a sense of where people are at. But certainly, I'd say almost 2/3 of people now moving in this direction. There's a comment I thought was really interesting from Diane McKenzie, that segmentation also needs to follow what you know accounts for patient behavior and challenges. And I just wonder if there were any discussions at your OHT about just, physicians saying, well, I know that my patients and here's the challenges they're facing, or home care or the hospital saying this is, the people who are coming in, just that sort of tacit knowledge as well as the data. I do find it quite interesting that your data pointed to almost a third of all of your ACSC, the COPDs, coming from those lowest quartiles. It was all ACSCs. I think it was almost a third, the Q4, Q5 from COPD. That was quite remarkable. But were there anecdotes and stories that went along with that?
There were, but I think those are going to become more relevant in the co-design phase, because what was happening during the segmentation process with the data was, and I think a lot of people can probably relate to this, but a mistrust of the data. The data is telling you one thing, but anecdotally, you haven't experienced this, or the data isn't perfect because of this. And, based on frontline, this is actually what happens. And so, the anecdotes are incredibly important. And like I said, I think they will be incredibly relevant during the co-design process, particularly when engaging people with lived experience, not just, providers who are providing the care. But we had just found personally that during the segmentation phase, again, things were devolving into the circular discussions. And so that's when we brought in that messaging of, we're not going to be able to perfectly capture experience through this data. We're just trying to learn, and we're trying to come to a decision at this phase. And then once we start co-design, that's really when we're going to start to lean on more anecdotal experience.
Super, thanks. You're getting a number of compliments around this work, and people are very, very keen and interested. A few suggestions and recommendations around approaches, and also, compliments for the CHPCA, perhaps you know what that is, on the palliative approach. I think we're going to see more about palliative in the next presentation as well, and some other people putting in comments and suggestions regarding the Inspired COPD Scale Collaborative. I know that there's also a program called Best Care for COPD, I believe some of the OHTs are working with, and leveraging each other's strengths. So other people that have ideas, please feel free to pop them into the chat that might be relevant here as well. And I think Mike, I'm going to give the last comment to Mike Heinmarsh, who asked if you think this approach you've taken to look at COPD might be relevant for other chronic conditions in your OHT.
I think so. I hope so. So for us, so Best Care is available in the Southwest region. So based on the data, what I can say is that there's obviously a segment of the COPD population who are experiencing the benefits of that program, and that's fantastic. But there's obviously a segment of the COPD population that are not experiencing those benefits. They're being hospitalized for their COPD, which technically, we can say that might be an avoidable admission. And so we, through the co-design process and through really focusing on having the right voices at the table, I think we've we have like a 30-member task team that includes community paramedics, representatives from social services, pharmacy, a whole wide range of people. And so that's where we're really going to start to figure out where things are working and where things aren't working. And then depending on this, where this goes, I think it would be very easy to spread to other chronic conditions.
Great. Thanks so much, Lauren. Really appreciate your sharing, and many others online as well. You can go in and have a look at the chat. I think you're going to have some conversations with Mike Hindmarsh coming up pretty soon. I want to turn it over now to Caitlin Agla, who's picking up some really interesting threads in a different approach. And one of the things that I was really inspired by with the KW program is, the whole purpose of population segmentation is to set us up to be able to best match programs to patient needs in groups. And I thought that this was a really great example of working through what are the best ways to think about matching our program to patient needs. And so I'm going to turn it over to you, Caitlin, to share your story.
Thank you so much. Happy to be here. So next slide, please. All right, so as was mentioned in the introduction, I'm coming from the KW4 OHT. And just for those of you who may not be familiar, that's talking about the cities of Kitchener and Waterloo and our townships of Wellesley, Wilmot, and Woolwich. So I wanted to just start off by giving you a brief introduction to our community. And as you can see on the map there, the city of Waterloo and city of Kitchener are fairly small. We've got large geographic areas of rural townships around us. So the rough populations I've put on the side there for you to get a sense of, we anticipated that at maturity, our OHT would serve approximately 400,000 individuals. And you can see there that though the geographic area is quite large, our population is smaller in those townships. So 25,000, 20,000, 11,000, and then over 350,000 in the cities of Kitchener and Waterloo. And for our community, as I'm sure for others, the urban versus rural is very, very important. So our rural communities have a very high proportion of older adults, and there are significant barriers to accessing health services in those communities, including transportation, social isolation, financial constraints, as well as very practical things like stable internet, which I'll come back to with regards to virtual visits. So relying on virtual visits alone is and can be quite problematic. So we had to be very mindful of those things. And then in regards to our primary care system, there are some noteworthy differences. So I just wanted to also draw your attention to the fact that we have over 245 primary care physicians serving our community, and 90% are in the cities. So there's a great disparity in urban versus rural there as well. But less than 20% of our providers work in a interdisciplinary health team support type model or family health team type model. So there are a significant number of patients and individuals who are with what we call solo practitioners. Next slide, please. So in our OHT, in terms of choosing the priority populations, trying to go off of where the greatest impact could be had for building systems that would then support the rest of our community. Our OHT aimed to look at 3 priority populations, and those were the frail elderly, the homeless and precariously housed, and refugees. And then across all of those, we were looking at specific areas around mental health and addictions, rural versus urban considerations, digital solutions, transitions. And so there are working groups for each of those different areas. And in case you're wondering why was frail elderly chosen, a little bit of info for you on that is that 15.8% of our attributed population is over 65 years old, and we're projected to have 100% growth over the next several years. Chronic conditions such as COPD, dementia, and CHF are more likely. Palliative and dementia care costs are about 20% of our healthcare costs, and there are significant barriers, some of which are, the setup of our primary care, as I mentioned in the previous slide. Next slide, please. So one of our big tasks as a working group was, how do we get started? Frail elderly sounds like something we can all appreciate who might be in that group, but actually that definition needed to be further refined. We needed to look at best practices. We needed to really intentionally align with a local initiative, which was our Waterloo-Wellington Older Adults Strategy. That's a 10-year initiative that had already begun in our communities and had begun with the alignment of our previous LIN. So looking at Waterloo area, but as well Guelph, Wellington, Cambridge, and its rural areas. And also trying to ground ourselves in health system priorities, all of which needed to, most importantly, focus on the client experience. Next slide, please. So in terms of the alignment with healthcare system priorities, we wanted to, of course, look at our OHT and what were the indicators or deliverables that we were trying to be accountable for. Caregiver distress, our expenses and number of people hospitalized was key there. I also mentioned to you the older adult strategy, and this is a huge report gathering info, gathering surveys and client experiences, and I'm happy to share that with anyone who's interested after the fact. But two goals in particular stood out, and that was the capacity of our health system, how it's designed and how it's coordinated and integrated, and what collaboration really looks like. So those were key alignments for us. And as well, we turned to the regional geriatric program for some guidance, and in particular, their senior-friendly care framework. So looking at their priorities around interprofessional models, integrated care, and looking at all the different domains of health for an individual. Next slide, please. We also did a lot of work around deciding for ourselves, what does frailty mean? And came across a ton of literature, which really just helps us to see that this is an ongoing definition and piece of work that's happening. And so we came up with certain principles and research-based information that would help guide us. And this was, just to go back to something that Lauren mentioned, this was super important to us so that we made sure we weren't just talking about programs that were good or things that sounded interesting, that we were continually grounding ourselves in what would make a difference in terms of frailty. So for some background info, I won't go through all of these, but one of the things that was looked at, and I've put a link to it in my slide there, is that in primary care, 25% of adults 65 plus are at risk for frailty, and 5 to 7% are frail. So this automatically helped us look at what is like the size of population we're looking at. What could frailty mean? And this was something that was looked at through the assessment urgency algorithm. So those scores are indicative of the level of support someone needs or chronicity of their conditions. And so this was really important as one step to ground ourselves. Next slide, please. Some of the guiding principles we also looked to were looking at transitions, really focusing on who is this person and not necessarily just our program. So not just sticking inside of this is what we do, this is what we offer, but what do people actually need? And is that the thing to ground ourselves in? Trying to be strategic as well to embed ourselves in existing systems, to not start recreating things or making a whole host of new things to do, but how do we redefine or pivot what we already have? Trying to build on that senior-friendly care approach from the RGP. And we really, really loved this question of how are people's stories being told? How are we looking at someone's journey through healthcare, and how are we labeling or looking at things, and how are we moving people around? Next slide, please. So we came up with what we refer to as a system level approach. So as a working group, we're trying to funnel down and funnel down and funnel down from, first of all, this label of frail elderly to what does that mean in the literature? What does that mean to us? What are the different perspectives around the table that we can pull from? And then trying to set up some priorities. So we came up with the 3 pillars here of delirium, functional decline, and palliative care. And how we came up with those was looking at our hospitalization rates, looking at what are people coming to EDs with, what are our numbers in our primary care practices, looking again at that assessment urgency algorithm, and finding that delirium and functional decline and palliative care were the things that most often took people to the ED. They were the things that were most often hard for our solo physicians to manage independently. And remember, that's more than half of our primary care providers, as well as the cost or number of visits that might take place. And looking across each of these, how do we intervene and also prevent in those areas? How do we use virtual care in those areas? And then trying to demonstrate those through our year 1 projects. So again, I'll go back to something Laura mentioned around building the plane while you're flying it, very much our experience as well. So we had to come up with what our year 1 projects would be at the same time as we're trying to figure out what we're doing. So these projects on the side here, these were areas that were already areas of concern or innovation in our community that we felt were already working towards the deliverables of our OHT, so they were well positioned to help us advance the work. So just also to highlight here, paramedicine is a program that was just recently expanded in KW, so this was very exciting for us. Our geriatric medicine and psychiatry programs are really at risk in KW. We don't have community geriatric psychiatry right now, and the medicine clinic was at a lot of risk for continuing. And then we had complex care program and regional memory clinic expansion as exciting initiatives happening as well. Next slide, please. And then through looking at a Kaizen event and looking at research that we had from primary care, we had primary care physicians, geriatricians, community support services, palliative care, all of these different specialties around the table, came up with what we felt would be a working model to help us, again, ground our work and move forward on where we could make an impact and where we could get started. So one of the things we really felt we needed to emphasize and look at were the transitions that people had, not just between our programs, but in their healthcare status. We had to also look at how we implemented palliative care. Again, this was one of those topics or areas where everyone kind of knew what we were talking about, but we didn't have good information for how or what we were doing with it and what it actually meant to implement palliative care. Looking at virtual and in-person visits and where they were appropriate. So with our frail elderly population, we had good research that showed us that it is not a great method for a lot of things that we're trying to do. It can be very helpful for check-ins and touch bases. It can be helpful for family appointments and things. But as I mentioned, it's not great for all of our rural patients and caregivers if they can't access the internet to do it. It's also not a great initiative for when we're trying to assess complex health conditions such as dementia and delirium, where we need to see someone, touch someone, look at someone, see them do something. And we also really wanted to look at how we could have one central route for people because there are too many ways into our system and people were getting lost and quite confused. So trying to look at that as much as possible. Next slide, please. So here we came up with our quality improvement test implementation project. So this was taking all of this work we had done to be funneling down to who the population was that we could work with. And we just recently did a seed funding proposal to our OHT that was accepted. And so the purpose of this was to build new care pathways to try to move away from very siloed care to care that was truly and deeply integrated with each other, to really align our memory clinics, our geriatric medicine clinics, our specialized geriatric services, our community support services. And I've made a note here to lay the foundation for geriatric psychiatry because we know we need to bring them into the fold. Our tasks were to wrap supports around clinics, create those integrated care teams that do not exist for much of our solo practitioners, and really embed palliative care and advanced care planning. So the group we decided to start with, thinking of all this information to date, was the waiting list for specialized geriatric services. The reason for this is we have a timeline of 6 weeks. So again, referring back to some of the wisdom that Lauren shared, we had to be really practical. Where can we make an impact in a short amount of time? We can't take on the whole city. We also didn't feel there was fairness in arbitrarily choosing a group of physicians, one over another. So we looked at this group that's waiting because they are experiencing chronic care conditions. There is an element of urgency and they are using the emergency room while they're waiting. And as well, the majority of people on this waiting list are from solo practitioners in KW. So the majority of referrals to specialized geriatric services are not from our FITs. Some are, and they're appropriate, but most are not because they're solo docs trying to manage this all on their own. And how we're embedding palliative care is trying to do some education and action. So we are bringing into the care teams a palliative care coordinator from hospice who can go over with the patients, or excuse me, with the care team, all of the patients and make suggestions right in the moment in the meetings about who could benefit from palliative care and make those warm referrals immediately. In terms of advanced care planning, how we're building that in is we have a group of advanced care planning volunteers who are booking direct appointments with to give consultations to patients. And then they're able to communicate back to the integrated care team. We're going to be using hypercare to have secure communications. The integrated care teams, I saw something pop up in the chat there. They are going to be nurse practitioner, nurse, community support services navigator, the palliative care coordinator, as well as the primary care physician. And then we have secured sessionals to bring in geriatric medicine, as well as our digital supports team and our health assessors to try to grab outcomes, and our coordinators and so on. We also have a project manager who's leading all of this work. And so I hope that helps to give a sense of how we move from a very abstract concept of frail elderly, and then through looking at the research, looking at a Kaizen event and looking at our experiences, began to work down to this very specific group that we're piloting this work on. We're trying to wrap around these patients from a complex care approach and support in return those primary care providers. Oh, and I should say, sorry, we also have pharmacy as part of the integrated care team. And then hoping with demonstrating how this works, we can expand it and use it as a model of care for our community.
Thank you very much. And I think that's a really, really great story, as I mentioned, to tell, and really interesting. I'm going to pop off one of the questions that came up and move over to a poll that we have. And there's a question about, you talked about many of your patients actually being in primary care models that were not teams. And I think hence moving to this sort of, way of developing integrated teams to support the patients. Do you have any sense how many of your patients may not be attached at all?
Oh, not attached to any primary care provider at all?
Yeah, I think that was the question that came up.
Yeah, I'm going to tell you my guess, but I would love to get back to you with a more appropriate confirmed number, because I believe we were looking at around 20% were not attached, but I would like to get back to you with a confirmed number. It's a pretty significant amount.
Yeah, that would be significant at those kinds of numbers. And also it bears reflection on how do you reach out and find the people you're looking for.
Yeah. Not to mention, we realized a lot of our referral systems are set up to refer, or that you must have a primary care provider. So by the way we've set things up in this kind of scenario, we're missing a ton of people to serve.
Right. And I am going to now just put out this poll. And ask if people maybe, I just want to get at this question a little bit of matching programs and interventions. So my poll question out here is, how are you working to match programs or interventions to meet population health needs? And I'm wondering if people are taking like, let's just go out and inventory everything possible, or maybe focusing and leveraging on strategic or specific programs, or starting fresh really, because co-designing new programs and pathways, and then otherwise maybe having some people out in the field to tell us if they have other suggestions. So people are just chiming in now with some of the ways that they are going about, and not just related to this, obviously, frail older adult population, but any population that you might be focused on. More people now coming in, and a couple of the ideas. So like, actually, Caitlin, when you seem to have taken, I would suggest you looked at other strategic priorities that were going on in the region. And that was one of the, and I think that might have led you to certain programs as well. Would you say it didn't look like you'd taken like, we're going to look at everything that might be available in every corner of our region? I'm not sure.
Yeah, I'd say it was a bit of both. And thankfully, I don't have the time to really go into all of it today, but the work of the older adult strategy did a lot of this for us. They did a lot of inventory, and they did a lot of engagement and coming up with a lot of this information that we could then pull from. So we had one of their co-leads join our co-lead group as well, so that we could make sure we had the wealth of that information brought into the frail elderly work. And as well, I think there was this duality between trying to be very thorough and not give preference or move forward with programs we just knew of, but also this time pressure to start to do things and start to move something forward. So I think they were happening really in tandem, if I can say.
Yeah, and it sounds like actually in our poll, many people will take a tandem approach, because people are checking into multiple options here. About 40% saying they inventoried all programs, but 64% saying they focused on specific programs, and 47% saying that they really look to co-design new programs and pathways, and a few saying something new, and we're hoping they pop something into the chat to let us know what that was. It is a mixed, but people definitely taking this multiple approach. I guess it sounds like you were able to build on prior work too, which is a real great opportunity. I want to take a chance here also and take that off and maybe actually take this down for a minute. I might come back to Lauren after as well. This notion of how do you match the programs and areas of focus, because you took this system level approach. And when you took like a system level approach, how do you said in your frail older population, there's, I might not get the numbers right, about 5 to 7% are very frail, 3% or the most frail, I think 25% at risk. Some can't remember the exact numbers. It was along those populations, but does everybody get the whole package, or are there going to be different tiers? Have you thought about that?
Yeah, so frailty assessment, it's done in our community in two kind of primary ways. One is the C575 approach, which looked at a level 1 and a level 2 assessment. And we're also using the InterRye screener and COVID checkup. So those are being used. It's a great question. I probably should have elaborated on that. I'll do that now. So in terms of our pilot, the SGS waiting list is having the InterRye screener done on all of them to start to tell us who is best to go off to which service and be really pragmatic. So who needs a referral to an internist, who can be seen by our local program, Jerry MedRisk, for medication checkups, and then the most in need of a medication checkup with a pharmacist one-on-one are reserved for that process. So it's constantly trying to use those validated tools to tell us how best can we stream people and get people into things as efficiently as possible. And we're really trying to use the things we already have as much as possible.
Yeah, thanks for that. And Lauren, I'm going to come back to you and ask you if in Chatham Kent, if you've had some conversations around how are you going to get at the right people, and I don't know, maybe if you have ways of case finding and ways related to equity too, if you're looking to target people of lower socioeconomic status, material deprivation.
Yes, so this is again where the research and practice kind of butt heads. So we did have a conversation the other day about our co-design process. So our co-design process, we essentially had some initial funding left over. So we're bringing in a quality improvement educator to help guide us through our co-design process. And we had to have a conversation about introducing some boundaries. Which patients are we going to focus designing these integrated care pathways for? Because, naturally, of course, people, frontline providers know that, if you start trying to capture and take care of mild to moderate, complex people living with COPD in retirement homes and long-term care, et cetera, the process can quickly run away from you. And of course, me being the researcher, I'm like, yes, with population health management, everybody. So we just had to make a decision that in order for this process not to run away from us, for the time being, we're currently just going to focus on mild to moderate cases, so people with a confirmed diagnosis. But knowing that case finding is an important approach or an important aspect of population health management that we are not going to be addressing right now, but we'll be mindful of, I think, once this work is a little bit further along.
Yeah, great. Thank you very much. And I see Caitlin, you've got your email out there now. So I know that right from the very beginning, one of our very first webinars, we talked about logic models, and we had a few OHT. I remember Jagger being on, and then they started getting lots of follow-ups after, and it just starts to build community amongst people doing the work, and I think people can share ideas back and forth, and I think you're getting some real positive comments in here. One from Christina Clark, great using a QI approach to manage and scale change and improvement, right? So start small, iterate, and I think that that's a great strength to the work. And I think that's generally across all the OHTs. As Lauren had said, don't let perfect be the enemy of good. We're really needing to step forward, step into it, and try some points of change. And one of the things we've found in all of this work is the importance of trust among people within the OHT and the relationships that are built. And one of the ways to build that trust and relationships is by working together and trying things and having that time and both succeeding together and sometimes failing together and learning from it and iterating. And that's the QI approach, right? It's not perfect the first time. Thank you so much. And I think there are maybe a few other comments coming in here. I'm going to come back up and share the right PowerPoint slide book again. Okay, and now I would just like to bring it to our next guests, Darren Gerson and Holly Opara. Didn't get that quite right, Opara, to join us today. And I'll say Darren and I have had this conversation running, and he's shown me some data decks, and I showed him some data decks, and there's just all kinds of data. So I'm really looking forward to seeing this presentation come to life and to hear Darren and Holly talk about how North Toronto has been trying to use data to advance their models of care. I'll turn it over to the two of you.
Thanks so much, Walter. So if are you handling the slides? If you don't mind going to the next one, that would be terrific. So this is us. And so certainly the interesting part of the presentation is going to be handled by Holly as we move through the slides in a little bit. My role right now is going to be to set it up and provide a little bit of context to some of the questions we've been asking, some of the thinking that we've been doing to help you and perhaps as you go down this path as well. So we go to the next slide. Again, who is the North Toronto Ontario Health Team? Well, you can certainly see the partners down at the bottom. Again, we've got logos of those that are at the table. The vision up top is important, but really what we're talking about today is about how we are using data to create those connections. So you can see our vision is to become one connected system. Today is really about how we're using data to enable those conversations. And there have been many, and they have been diverse. And today you'll get a bit of a sampling around what that looks like and what that feels like. If you can go to the next slide. So this is a really simple slide, but I smiled as Walter just said, don't let perfect be the enemy of good. And this slide really exemplifies that to a great deal, right? So, what we're seeing here is really at the root of many of our planning discussions. Our attributed population consists of 187,000 people. But like most OHTs, we don't really have a clear line of sight into who those 187,000 people are. Some might have better data, better insights into who those people are. We do not, and I know that many OHTs don't have perfect insight into that. Instead, we continue to talk about geographical boundaries of North Toronto, where we know about 230,000 people live. Okay, well, that's good. But we know this is problematic, but when we get into segmenting the data, and certainly segmenting using CIHI's populations, you'll see Holly present to you, it has really allowed us to have some very important planning discussions that cross boundaries. They could be attributed to the attributed population. We can talk about geography, but when we start to segment at a detailed enough level, it has really allowed us to have the important conversations that we need to have to think about population health management. So today you'll start to get a glimpse of what that looks like in some of the discussions that we've been having with our operational leaders. You can go to the next slide. Now, just before I hand it over to Holly, like I said, for the interesting bits, what you see on this slide are the questions that we're trying to answer. So who is accessing healthcare? What are the most common healthcare conditions? What are the future health needs? And certainly you'll see that we have a glimpse into what that looks like. Are there any specific priority populations? So each OHT has identified their priority populations. We can use these tools to actually focus and drill down into those priority populations to some extent. And below, what you can see is our segmentation approach. There's lots of different ways to segment populations. What the CIHI tool has allowed us to do is to look at the 6 that we have focused on in this particular presentation. And the beauty is that we can cross-reference them in any way. So you can look at demographics and geography. You can look at geography and health conditions. You can look at them any number of these together, and very often you get very, very detailed very quickly. So that's the setup. I will turn it over to Holly to show you some of the amazing data that she has put together, and I'll come back at the end to bring it all together.
Awesome, thank you, Darren. And Walter, if you could go to the next slide, please. Great, okay, so on this slide here, you know, as Darren kind of mentioned, there are many different ways to splice and dice the data. And so today we're gonna kind of walk you through the different ways that we segmented our data, whether it's looking at like demographics, equity, geography, kind of the slide you just saw previously, so that hopefully we can help you understand your own data and populations of interest should you choose to use the CIHI Population Health Grouper. So this is a data set available through Intellihealth, and the best thing about Intellihealth is that it does have record level postal code data available. And so with this data, you are able to map postal codes to specific neighborhoods within our subregion, using our kind of North Toronto, Toronto Central Lynn subregion boundary. And so as you can see here, we've been able to bring our analysis down to a neighborhood level by mapping postal codes to neighborhoods. So kind of our initial approach to understanding this massive data set was really to just get an understanding of who our population is. And so on this slide here, you can see 4 different graphs looking at demographics, so where residents live, in which neighborhood, income quintiles by neighborhood. We looked at the population pyramid, so to see what our age categories are and the distribution of sex within the North Toronto subregion. And then also a little graph on the number of health conditions by age. And so again, there are many different ways to kind of splice and dice this data, but this is what we did to kind of give us a broad sense and overview of our North Toronto subregion. To go to the next slide, please. So on this slide here, the first kind of question that Darren alluded to was who accesses healthcare services within the North Toronto subregion. And so this is looking at health system utilization. You can see on the slide here that there are 3 kind of categories in the data set. There are non-users, which are in blue, who have not had any contact with the healthcare system in the past 2 years. There are users without health conditions, which is in green. And these people have had contact with the healthcare system, but have not been diagnosed with a health condition considered in the CIHI Pop Grouper data set. And then in orange, there are health system users. And so this user group can be drilled down to further, which we'll see in a few slides, but we've kind of brought it up to this level to really get a basic understanding of who does and does not use the healthcare system. You can also see on the slide here the Ontario average, and so this really kind of allows us to have a baseline value or baseline understanding of who does and doesn't access services within Ontario. And you can see that roughly on average, 15% of our individuals within North Toronto do not access services. And so this slide has generated a huge amount of discussion within our OHT and at our ops committee, because we're able to see who is least likely to access services. And we know that this could be for a variety of reasons, but most likely it's that their healthcare needs are not met, and they may require more complex and frequent care in the future. And so conversations at our ops table is really looking at how can we connect these people to resources to better meet their healthcare needs. Next slide, please. Great, so on this slide here, you can see the 3 kind of segments of utilization. So the non-users in blue, the users without health conditions in green, and then now you see the orange users kind of split up into what's called a health profile group. And a health profile group is just a data field in the POP grouper, which is the most complex and clinically relevant health condition present. And so we wanted to get an understanding of patients in North Toronto, like what are the most common health conditions driving clinical care. And so as you can see here, the top 10 account for roughly 30% of our North Toronto residents, and they're mostly minor and acute in nature, which suggests that they're sitting at kind of the bottom of the population health pyramid. And you can start to look at like self-management or preventative interventions to help kind of manage their condition and limit disease progression. Next slide, please. So these on this slide here, you're seeing now those top 10 clinical health conditions by volume, segmented by prevalence and neighborhood. And so really seeing this level of data at the neighborhood level really allows you to understand, the average of prevalence of conditions by neighborhood. And you can see kind of which neighborhoods have higher or lower prevalence of conditions. So for example, I've called out to like one neighborhood with a higher prevalence of minor acute respiratory conditions and a lower prevalence of neurotic anxiety and OCT conditions. And so really this can spark discussions around, why this may be. Are there barriers to people accessing mental health services in Angle Mount Lawrence? And can really be used to help inform and target interventions specific to population needs, because you can see on the graph here, not all neighborhoods have the same healthcare issues. Next slide, please. So this again is the top 10 health conditions by volume, but now looking at the total cost for this year and next year. Really interesting data provided in the POP grouper data set are these data fields called resource intensity weightings. And what these are is basically an estimate of the resources needed to care for your current clinical condition. They give you 2 kind of years worth of health resource intensity weightings. One is a concurrent period, a current period, which is the previous 2 years worth of data. And then the second is looking at the prospective period. And that's kind of next year, what your health needs might be based on cost. They also give an average value per average cost per person for healthcare in a year, which is roughly about $2,000. And so to get the concurrent and future costs, you can take the individual row level RRWs, multiply it by that $2,000, and then sum up the total for the concurrent period and the prospective period. And so this analysis is directional in nature. It really allows you to understand, what the future healthcare needs are and what your future cost drivers are. Again, this generated a ton of discussion with our OHT because we were really interested in that non-user segment. You can see that since they haven't had contact with the healthcare system this year, they cost us nothing. But then next year, they contribute significantly to our overall cost with a cost increase of $8 million, which means there is significant resources needed to meet these people's care needs. And so really looking at how we can help keep people at the bottom of the healthcare pyramid and kind of hopefully focus on reducing cost increases in the next year. Next slide, please. So switching gears a bit, what you just saw was about the most common health conditions and the different ways that we kind of sliced and diced that data. This is now looking at the mental health and addictions related conditions within our OHT. And mental health is a population of interest within the North Toronto OHT. And so this is what the prevalence of conditions looks like in our subregion. Being able to identify these health profile groups is quite easy within the POP grouper. We're able to pull through the health category, which is another data field in the data set, giving broad information about the clinical condition and its severity. So whether it's minor, moderate, or major, and then acute, chronic, cancer, or mental health related conditions. And so we pulled all health categories related to mental health and addictions related care. And this is kind of what they look like at our neighborhood level. Again, here, seeing it at this very practical level, you can understand which neighborhoods or communities might have higher or lower prevalence of different conditions to see kind of where you can better target interventions and better support individuals within these neighborhoods who have these conditions. Next slide, please. There's also in the POP grouper data set an equity proxy looking at income quintiles. And so we know that people don't experience, or the outcome of health isn't experienced equally within the population. Some certain groups have greater advantage of accessing services than others. And so really we wanted to kind of embed equity throughout our analysis as best we could. And so this is one way you can do it. This is the top mental health and addictions related conditions segmented by income quintile. And so the North Toronto subregion is quite wealthy. As a baseline, we have about 65% of our geographic population in the highest income quintile. So nothing here seems too surprising. But again, you can see deviations from that average. You can see that conditions like dementia, delusional disorders, drug and alcohol dependence seem to be greater impacted within the bottom or more marginalized peoples. And so again, you can start really embedding your analysis and understanding who are these people and what might their care needs be to help think about designing interventions to meet their needs. Next slide, please. And then finally here, so you've seen the common health conditions you've seen a priority population on mental health. And then this final slide here is really looking at a priority population by unique postal code. And so our OHT has been looking at designing interventions for frail seniors at 4 Toronto community housing buildings, which is, again, frail seniors are another priority population of interest for us. And so each of these buildings are quite large, and they're represented by a single postal code. And so the benefit of this is with Intellihealth, we have postal code level data. So we were actually able to pull the 4 postal codes representing these 4 buildings to really gain an understanding of who these people are in this building, what their health conditions are, and what might be some sociodemographic factors we need to consider when designing interventions. On the surface, initially, they're all frail older adults with complex healthcare needs by the same service provider at a Toronto community housing building. And so you can kind of start gaining a sense of what these people might experience. But when we're bringing it down to this practical postal code level data and sharing it with our clinicians, you can really see that the prevalence of conditions is quite different between these buildings. We brought this forward to some of our frontline clinicians at our operations committee, and it really validated their experiences within the building and resonated with them. I had one psychiatrist say during that meeting that building 2, they couldn't understand what about building 2 felt different, but they felt like they were providing a lot more mental health services, but couldn't explain why. And so showing this slide really validated that experience and allowed them to kind of understand what's truly happening in these buildings. So all this to say, we're looking here at a very hyper-local focused intervention, and you see that it can't really be a one-size-fits-all model for these 4 buildings, even if you have the same service providers present. And basically to say you need to kind of customize your approach to care when you're looking at these more complex top of the pyramid individuals. And so maybe now I'll pass it back over to Darren to share some key learnings and our next steps.
Great, thanks so much, Holly. Like I said, she had the interesting part of this presentation for sure. Certainly on this slide, Holly already highlighted the most important point that I wanted to talk about, and that is the 4th point on our key learnings. Certainly I can't emphasize enough how showing these data, certainly when we get to the more granular building level information, it really validated what the clinicians were seeing, what the health service providers were experiencing. And it actually built trust in the data, which I can't say enough about. If you start to trust the data and it starts to validate your experiences, being able to generate conversations about what to do next becomes a whole lot easier and it facilitates conversations. I mean, certainly this has been a significant contributor to our collaborative quality improvement planning process. Having these data in front of the operations committee has made an enormous difference. So certainly just a little bit of color to the description that Holly just provided around the building information has been really quite helpful. I see tons of comments. I'll get to them as quickly as I can and catch up. If we go to the last slide, before we open it back up for questions, certainly future data needs, again, while we address some of these questions in the chat, the Intellihealth data is a little bit old. It's probably, I think, 4 years old at this stage. That's not a barrier because, again, we're talking about population health data. We're looking at the entire population, not local areas. And even where we looked at buildings, it was still valuable to look at the trends that we're seeing within a building. Certainly, but more data, more current data will only help and will certainly prevent some of those that are maybe willing to dismiss older data as a result of them believing that doesn't represent current state. The second point, and this is one that Walter has already heard from me, and so have many people. I'm sure those that are on the call from ministry or Ontario Health have heard this. It would be fantastic to have the flag added to in Intellihealth to be able to not only have the de-identified encrypted healthcare number, but also have the attributed, the population-based attributed, the primary care-based attributed OHT assigned as a lookup table. Imagine the analysis that we could do with the primary care attribution model overlaid on top of everything that Holly has shown us today. It would be phenomenal additional information that can certainly only help understand our population and how to best reach out to them. And certainly at the bottom, some other thoughts around what is needed as we move forward. Certainly the ability to independently analyze our own data. Being able to self-serve is really valuable. You can slice and dice the data the way you want to in this way. And without a doubt, it is, to become true population health managers, that has to be in your toolkit as you move forward, as opposed to data packages that are valuable, but not exclusive to what's necessary in terms of pop health management. So with that said, I know we're running a little bit short on time, so I'll turn it back to Walter, and I'll try to catch up on some of the chats that are ongoing.
Yeah, thanks so much, Holly and Darren. And there has been a very active chat. Lots of people, some people haven't even heard of Intellihealth. Like, how do we get access? What if it sells? So Robert Barnett, I think, is a regular user. He's already got about half of them answered for you. Someone else suggested catching up on a bit of a poll to get a sense, or a survey to get a sense of what different data sources. So here's the first shot at this on let's finding out from OHTs what different data sources you are using. So I'm going to put this up into a poll, and here we go. So let us know the different kinds of data sources that you might be using. Is it local, primary care, hospital, home care, like just directly right off providers locally? Are you using primary data collection yourselves? Are you using Intellihealth, perhaps, and IDS or others? And if it's others, then please do tell us in the chat how else you might be accessing data. One of the subtle things I wanted to do in this event was to bring different data sources. So many people are accessing the integrated data system, the IDS that Lauren Tessier's group at Chatham Kent is using. Other people are using local, Gestalt approaches, relying on literature for prevalence, and maybe pulling out of some waitlist data as an example, some census data, to get a sense of their local population. And then there's Intellihealth here too. So many different approaches and different sources. And then I think just a chance for us to come together around this one question. And so let's, I think the poll is slowing down. We don't have as many respondents. Maybe not as many people are super familiar with what data sources. I suppose I didn't say none of the above. I didn't give that as an option here. Hopefully people are looking at some source of data, but I'm going to close it off and share the results out now. And you can see the most common approach by far is local data from health providers, and that's where people can actually access primary data from data collection surveys, and IDS are running around 30%, and about 1 in 5 or 20% are using data from Intellihealth, as you are. And I'll say, Darren sent me the one, an earlier edition where they had it, profiled down to a building, and you could actually take a look at what services people in that building were using. And I just thought how enlightening, because I know other groups are talking about congregate living and thinking about, what are we all doing in that building anyways? And that was, I thought quite enlightening and quite useful. There are many opportunities, I think, to discuss relative trade-offs of IDS and Intellihealth. And just like there are many ways to discuss trade-offs between the BC Health System Matrix and Chi-Hi Pop Grouper. And I think we're learning, and we'll leave it that at this point in time. But if people want to pop into the data chat, anything around, what kinds of data sources measure you're wanting to use to monitor and report. I'm going to jump the question queue, Darren and Holly. You might have one or two that you're looking at, but I'm going to jump the question queue and ask you, because it certainly is something that vexes me. I spend a lot of my time looking at health utilization data. and that means like people who have encountered into the healthcare system and realized access data. And yet when we think about, the planning work that is happening in Waterloo, or the other work that people are trying to do, really trying to get at needs. So where are the needs of the population? And I'm just wondering if you have any reflections. You're looking at data that not that old. It's not all 4 years old, I don't think. Some of it's a bit more recent, but it's realized use and trying to use that to backtrack to say, what is it that the type of care in a population health management, how do we organize around the type of care instead of just, they were here for a GI and then they were here for an aortic valve, and then they were here for, that's a lot of what ends up in the CIHI data. So if you could just maybe reflect on that a little bit.
I'm happy to start, and Holly, please do jump in. I guess what I would say is, if you go back to the name of the grouping, the stratification variable that we're using, it's called the health profile group. So it's actually less about the individual acute event and more about what is happening to that patient over the course of the period of time that the patients are being considered. So it does, the POP grouper does include primary care, it includes emerge, it includes acute care. So it really does, profile the population. So, and if you remember what Holly showed in one of her early slides was most of the top 10 or the highest volume HPGs that represented 30% of the population were those that were fairly minor in terms of health needs. So that, if you take that context and you think about it from that perspective, when you look at it at a very local level, like at a building, and compare one building to another, it helps us to really reinforce that not every building, not every neighborhood solution could be exactly the same. There needs to be some customization and some focus that these data can really help inform when you start to think about the profiles that we're seeing within the population, as opposed to, did you show up and emerge on February 22nd? So that's how we are using the data to facilitate conversations and planning.
Thank you. Do you want to add anything to that, Holly? Diving deep in? No,
Nope, I think he covered it well.
Yeah. And so I think, one of the things I think that Lauren had just popped into the chat was Intellihealth's more of a self-serve service, and IDS comes with a little bit more support around and things. And it was one of the useful, and I think Wendy is noting in there some of the resources that are available through each. There's no perfect world. I think Ontario Health has just collected a fair bit of information from all of the OHTs. So back to the earlier question about what are people using, might be available from there, where people are getting supports, and hopefully they will solve all of our problems in the next, I don't know, a few months or so. Should be okay. Is there anything else that you had noticed, Darren, in perusing the chat that you wanted to catch up or pick up on in specifically?
I think Robert answered just about everything, so thank you for doing that. If there's anybody that is waiting for an answer, please feel free to speak up if you can. I'm not sure if they have the ability to do that or not, but maybe just state it again.
And I think I'm also conscious that we're pretty well at time. And so I want to just thank all of our speakers today. It's been a very active discussion. I've learned a tremendous amount, and I think for OHTs out there, just knowing that, nobody's got it perfect yet, and don't let perfect be the enemy of the good. We're all working hard in this space. Just a reminder that we have webinars every month on the fourth Tuesday of the month from 12 to 1:30. They are always this exciting. We peaked at about 279. We still have over 160 people online right now. And I say people come for the content and stay for the chat. And I think that's true again. So thanks very much as we share learnings across Ontario Health teams. Thanks so much to our speakers. Thanks to Nusrat for keeping us running. And we will be back with more stories, early learnings from developmental teams, patient provider surveys, and we'll be back to let you know how the results come out from our Ontario Health Team Survey 2.0. Welcome, everybody. Thank you. Have a great afternoon.
Thank you.